Welcome back, ladies and gentlemen. Welcome back. That's good. I didn't even have to name names. Before we start the second part of our panel, one announcement. The slide decks for all the presentations will be available after the conference on the CHSPR website. So for those of you who are frantically taking notes or even pictures, you probably don't have to do that. Okay, we're going to resume with the Contemporary Canadian Health Policy Challenges panel. And our third speaker this morning, our third panelist, is Jerry Hurley. Jerry is the newly appointed Dean of the Faculty of Social Sciences at McMaster, and he has survived his first 6 months, having previously served as the chair of the Department of Economics. He's also a member of the Department of Clinical Epidemiology and Biostatistics and the Center for Health Economics and Policy Analysis, CHEPA, at McMaster. And as regards CHEPA, Jerry has actually served as the director of CHEPA on 2 occasions. He's also the author of the Canadian textbook titled, quite simply, Health Economics, which I guess Jerry says it all. He's written extensively about healthcare financing, and that's a subject he is addressing today. Over to you, Jerry.
Thanks, Greg. It's really an honor to be able to speak at this event because, of course, Bob has been one of the most influential people in terms of my own thinking about the economics of health and healthcare. So I'm really pleased to be able to speak to you today. As Greg said, I've been asked to speak to challenges related to finance and funding. And I'll just comment that when Morris asked us, this is what he told us. I noticed in the program he slipped in that we were going to propose solutions. So we'll see how we do there. But I want to talk first about financing. And I'm going to take as my starting off point one of my favorite papers of Bob's, actually. And I'm not sure if it's actually in the volume, but it's the 1983 paper on the welfare economics of public health insurance. And this is a paper in which Bob challenges the conventional wisdom on the economics of health insurance to argue that, in fact, there's a very strong, compelling economic case to be made for universal first dollar coverage through a public system, which, of course, goes contrary to almost all of the conclusions you would reach using the standard economic model of insurance. And that paper, I loved the paper. I still assign it to students, frankly. And he, of course, then went on and developed a more fully enstrained Mercy. And really the kind of first 4 chapters of that book are, in some sense, a development of many of those ideas, along with many others that he's, of course, developed over the years. But I want to take off this idea that, of course, the universal public system is economically a very sound approach to financing healthcare. And in some sense that we got it right in that respect. Lots of things we didn't get right. And I say that notwithstanding our earlier speakers, which of course is we didn't cover as much as we should have. We should have brought in drugs and dental and everything else. But in fact, the idea of a single payer universal system, and what I want to focus on is what I see as some of the challenges to maintaining that vision for our system today, again, notwithstanding that it is perhaps incomplete in terms of what it covers. So let me first start again with focusing on challenges I see at the public-private border, because of course the challenge is all of the persistent efforts to bring in more private financing of a certain type. And again, private financing per se isn't always bad. If it's not medically necessary, if it's something that shouldn't be in the public system, of course, that's fine. But all of the challenge is to saying we should be changing the model by which we finance healthcare in Canada. And the first thing I want to focus on as a challenge these days is, of course, anemic economic growth. Now, notwithstanding our first quarter that was surprisingly good, that's right. I wasn't surprised because I swore off macroeconomics once I passed my comp. And I promised I would never say anything more about it, and I'm violating that right now. But nonetheless, the point is, we seem to be stuck in a mode of very slow economic growth. And in fact, this is the trend over the recent decades in economic growth. And this poses huge challenges, of course, for governments to finance the necessary public services that we need. And in fact, I mean, it's projecting economic growth of kind of 1.2, 1.5, right? We used to see numbers 3, 3.5, 4. And so this is going to severely constrain governments in the coming years, depending upon how long we get stuck in this mode. And this is only going to increase the pressure on saying we need to look at other sources of finance. The system's not sustainable. You're familiar with all of the arguments. And so I see this as a very real problem that governments face that's going to exert considerable pressure to, in some sense, change the way we finance healthcare because, once again, it simply won't be affordable in the eyes of many of the, and we're all familiar with all those arguments. But in fact, this is a very real underlying challenge that we face, which those of us in the healthcare sector can't do a huge amount, but nonetheless, it sets the context for all the debates and discussions in which we engage. The second point I want to raise, and only briefly because, I mean, Colleen alluded to these this morning, and she's much more knowledgeable than I am about many of this. And this, of course, is the court challenges. The Brian Day Canby Clinic challenge here in Quebec, in British Columbia, Chaouli from Quebec, the Ontario case that's moving forward. And I raise these for a couple of reasons. One is they have the potential, of course, to simply overturn and say that, in fact, we no longer can prohibit or even just regulate insurance and physicians' practices in the way we have historically. But more to the point, because I think for us as researchers and policymakers, it's a very different arena than we've been used to playing in, right? We've been used to working in legislatures and other sorts of arenas where there's a lot of back and forth. And this is a courtroom in which evidence is being presented, the standards of evidence are different, the nature of the decision is different. It results in a clear kind of winner and loser. There isn't a lot of negotiation going on. And so we're going to see more and more of these challenges around different aspects of how we finance healthcare and the way we regulate the providers within our system. So I think this is clearly introducing a whole new dynamic into the health policy arena in Canada that is probably only going to grow over time, right? The Charter is becoming more and more embedded within our society and the way we think about resolving issues. And so I think we really need to come up to speed on how to think about the courts as an arena in which policy is being made, in a very different arena than most of us are used to thinking about. Next, I want to focus on some what I call supply-driven pressures. And the first, of course, is growing physician supply. And many of you are familiar with this kind of a graph. This is the enrollment in medical schools in Canada. And you can see starting in 1980, and you can see the huge increases in the last 15 years, increases that frankly they've slowed, but we still registered an increase in how many physicians we're training last year. And this has huge implications for what's coming down the pike in terms of pressures on our system. And I think we're going to get it both ways. Because if we allow them all to practice in the public system, that's just going to exert enormous pressure. So again, a kind of analysis Bob led and has been a major actor in understanding the dynamics of physicians within the system and as, in some sense, a cost driver. But if governments hang tough and say, sorry, we're going to have some unemployed physicians because we can't afford you, that's just going to open up and create a whole bunch of opportunities of people seeking to make a living in the private sector because they don't have access to the public sector. And so that's just going to create a whole new avenue of pressure that's going to exert itself in terms of the dynamics of our system. And in fact, that whole process is being fed by the increased number of private clinics that we're observing in Canada, right? This is an example of a website now. You need a private clinic? Here's a website for all the clinics in Canada, depending upon what you need, right? This sector, of course, has been growing. It's getting entrenched in the system. So there'll be a welcome place for some of these physicians to go. It represents both a mixture of things that, of course, are unnecessary and shouldn't be in the system, but also increasingly bleeding into providing services that are medically necessary, often violating the Canada Health Act as we understand it. Because, of course, again, as Bob has so eloquently written many times, these forces are partly driven. So some of these clinics are because governments are contracting out, and a certain kind of static analysis says, well, that's fine. Governments can choose to contract with a private provider, or they can, of course, build it themselves. But in fact, there are some compelling reasons why in a certain kind of static analysis you might want to contract out. But what it ignores is what Bob was referring to this morning, which was the political economy of this sector, which is once it gets entrenched, there's private capital that's been invested that's going to seek a return. And it's going to constantly press and push the system to say, give us access to more of your patients under better terms and conditions. And that leads to things like this, where Saskatchewan passes a legislation that says, in fact, patients can pay privately for their MRIs, only if the clinic agrees to voluntarily provide a public patient with access to an MRI. Right? And so somehow there's this patina of somehow helping the public system, when in fact it's not going to play out that way. And it's just increasing the market and the opportunities for the private clinics to, again, increase pressure on the private financing. And it leads to things like this in Quebec, which is essentially has now legalized a whole range of fees that essentially violate the Canada Health Act. But of course, in a situation where for 10 years there hasn't been any enforcement, whether good or bad, Colleen, this is allowed to thrive. And so we're going to see this sector is growing, it's developing, it's here now, it's not going to go away. And so how are we going to deal with this in a context where we want to try and maintain these key principles of how we finance our healthcare system? Added to this, what I call the supply side push coming out from the physician side and the growth of these private clinics are what I'm going to call some demand-driven pressures. One is simply healthcare as consumer good is changing. The range of things that are, in fact, not medical, the range of healthcare services provided by your physicians and other providers that is not medically necessary is growing. It's expanding. As we joke, there's a lot of vain baby boomers out there who are willing to pay to have all kinds of things done to stay young. You can't read this, but this is cosmetic surgery and growth rates for certain kinds of cosmetic surgery. Notwithstanding various buttock augmentation implants and other such things which are growing at 100% rate, even things where there's a base of millions and millions of procedures are growing 9%, 7% a year. Right? This is, again, it's fueling the clinics, and it's fueling this kind of thing. In my mind, and here, François, I'm starting to sound a bit more like a sociologist, so forgive me, but we know that when you make clear distinctions between different regulatory regimes and different categories, when the services are very different, people can maintain that. They can understand it. There's no cognitive dissonance as to why this is treated this way and this is treated that way. When we now have all these services where you're going to your GP, you're going to your dermatologist, you're going to your surgeon, and you're saying, well, I can get it fast and pay here, and it's not really even necessary, and over here, it's really necessary, but I can't get it. You start to say, wait a minute, what's the difference here? Why is there this different, what's going on here? And if we don't have a really good answer, it's going to wear away, I think, in certain ways, at people's commitment to certain kinds of principles. Another aspect here is what I'm going to call the changing norms about queue jumping. An example, here's Canadian Living, right? The magazine our mothers and grandmothers used to figure out what side dish to serve at Thanksgiving, with 9 ways to jump the healthcare queue, right? I mean, HOV lanes, they started for environmentally responsible people who could get there faster because you're carpooling. Now, if you pay, you get access to that lane. You get stuck, you don't like waiting on the phone, you can pay a fee and you can jump all the people in the queue to get your question answered. Going to prison in the U.S., you can upgrade, and if you have money, you can pay for a better cell and better conditions in certain prisons in the U.S., right? This is this is, and what I'm saying here is just, once again, what it means is it's going to seem more and more normal to allow people to jump the queue. Because why is healthcare different? What's going on here? I'm doing this every place else in my life. And again, part of it, we've always had privilege, right? If you had money, you could always get better access to anything in life. But we're starting to bring this into areas and arenas where we've never thought this way before. And it's hard to think healthcare wouldn't come up sometime reasonably soon in this list. So I'm pointing to simply here a range of factors on the demand side, the supply side, and in some sense the policy arena that I think are going to continually exert pressure to make it harder and harder to kind of maintain certain of the key principles that have been quite successful for us in financing our healthcare system. And there aren't easy solutions to some of these, right? Some of these, we have to rethink regulatory regimes in ways and to handle situations, again, to Colleen's point, that weren't envisioned 50 years ago or 40 years ago. And so we really need to spend a lot more time thinking about how to craft the kinds of regulatory regimes that can handle this new reality. And we're going to have to share information better with people to help them understand why it is the way it is. Because if they don't understand it, they're not going to buy in. So I think some really important challenges to which I wish I had clearer solutions, but I think it is a process of public engagement, a process of rethinking some of our regulatory structures to try and handle these new realities in terms of financing and maintaining the integrity of aspects of our public financing. I'll stop there in terms of financing and switch over to funding because I was asked to address both of them. Move relatively quickly because I have about 5 minutes left. I see the key challenge in funding these days is finding the right role for funding and financial incentive policies in efforts to improve quality, control costs, and kind of drive and support system change. Financial incentives have been promised by many over the years as the answer, right? They were really the fad for many years. Pay for performance and a variety of other kinds of incentives. We're learning that doesn't work out quite the way it was promised. Surprise, surprise. But I want to make a couple of distinctions here. One is funding really matters. And again, I would point to Bob's work over the years, documenting what happens when people are funded fee-for-service. Well, we know it increases utilization. We know physicians have control and considerable discretion. We have reams of data that show that how you fund the system. And by funding, I mean what's the basic way you provide resources to the providers and institutions in the system. It matters enormously for what happens, what they do, how much they do it, and so on and so forth. But we also have been learning of late that targeted incentives to change behavior don't work very well. They're highly unpredictable. So in the first case, the base funding method leads to very predictable, very consistent kinds of behaviors. In the second case, when we try and use financial incentives as this tool to guide behavior, particularly in quality control, this has been the fad in the last 10, 15 years, is to use financial incentives to target, right, only pay for results, only pay for what we want them to do. And this just doesn't work very well. And there's a number of reasons for that. But my main message is going to be we have to pay close attention to financial incentives. We can't ignore them. And this isn't a message saying ignore them, but it's saying we want to use them very cautiously. It's a deliberate policy tool. And I'll just go through a few reasons why I think we observe what we do when we try and use financial incentives in the health system to guide behaviors. And again, some work Kim and others and Ruth Laverne have been doing here at CHSPR documents just, again, in the case for BC, their pay-for-performance incentives just haven't worked. And they're just one in a long stream of settings in which that's the case. One is, of course, the nature of healthcare. It's very different than lots of contexts in which we try and use such incentives. First of all, it's non-financial. We don't immediately think of healthcare as a context of financial transactions. It's a context for norms and trusts and all sorts of other values. Most providers are motivated intrinsically in some way, shape, or form. Incentives are explicitly about extrinsic motivation. I think I have to offer you something to get you to do the right thing. And that can have profound effects when you start introducing incentives into this kind of a context. The meaning of what they are is contested. It's not the same as if I offer an incentive to a derivatives trader, he or she knows exactly what it is and exactly how they're supposed to respond. That's not the case for most health professionals. And so that leads to not just it being ineffective, but leads to highly unpredictable, often very negative consequences. And this is what I mean by the greater unpredictability. It's not just ineffective, it's that it leads to things we can't predict ahead of time, some very negative. Second, it's a very complex arena. We know incentives work for very simple tasks. We ask you to screw number 5 bolt on this bumper. Yes, maybe it works if we give you incentive. That's not what healthcare is. Healthcare is lots of different tasks. It's a very complex environment. And offering incentives for some but not others leads to problems. The last I want to emphasize is just importance of teams. Increasingly, we know that teams and team approaches is a way to deliver much better healthcare. We don't know how to design incentive systems for teams. Do you give it to the whole team, in which case there's then free riding and worry about all this coordination, or do you give it to individual members, at which point you inhibit cooperation and the collaboration that's the whole reason you established the team in the first place? So there's huge challenges for thinking about incentives in the kinds of contexts that we most want to develop in healthcare. So what I'm going to say in terms of way forward is just get the funding right, get the base method right, and that's a blend of some form. Though I think we have to think more broadly than we generally have in terms of the nature of the different kinds of funding stream offered to which different providers receive, to which providers receive. But here the idea is make sure you don't have the incentives get in the way of good people doing the right thing. Right? Don't think you're going to get them to do it because of the incentive, but make sure you're not inhibiting the right action. And second, think about incentives, financial and non-financial, in a very highly coordinated way, because what we've got to do is change culture, and that means hitting them in dozens of ways with little signals that are coordinated, both financial and non-financial, to lead to the kind of change we have to have in our system. So I'll stop there for now. Thanks.
Okay, we have some time for 5 to 10 minutes for questions or discussion. I'll just, if nobody's at the mic, I'll just start with a couple of notes here. I was getting depressed through the first part of that, Jerry. Let's see, the problems in financing are more physicians, slower economic growth, private clinics spreading, increased number of necessary services, unacceptable wait times, and increased queue jumping and paying for upgrades. Well, we should be able to deal with those, shouldn't we?
You asked for the challenges.
Yeah. Anyway, so then you went to some of the approaches that might deal with this, and the first part was the new regulatory regimes, and fair enough. But I'm interested in the second part. In order to have any support for any kind of new regulatory structures, you were saying we'd need better information to people. I presume you mean the public. And do you have any thoughts on how that public relations campaign to set the ground for new regulatory structures might unfold or might be created?
So I'll give kind of two answers, or two parts to the answer. The short, maybe three. The short answer is no. I don't have a clear sense for how to do it. I'm an economist. I'll wave that flag for now. That's strange you have a short answer. It's partly to help them I think many people don't really understand how the system works and why it's designed the way it is. Right? They really just it's never been explained. In the product challenges, this is a really hard thing to explain. There's a lot of very subtle points here. It's complicated, and we know that PR doesn't work well with complicated issues. They tend to get simplified, and that's the message that comes through. So it's a huge challenge in terms of information, but I'll point to just a couple of things. One is the evidence that people indicate that they're willing to wait if they understand it's because someone in front of them is more severely treated, needs to care more. They're okay with that. They don't want to be taken for duped into waiting when someone else gets it. And we've done some work in we have a laboratory in which we use some experimental economic methods. And in fact, we found exactly when we put them in an environment where healthcare resources were allocated according to need, the willingness to pay for healthcare insurance, private insurance to get better access, was notably less than when resources weren't allocated according to need in these environments. Secondly, they didn't fully appreciate how important need was. They had to learn over time the effects of when you allocate according to need, and they adapted, but they had to learn over time. The second work we did, I think, which is very important, which is about giving people opportunities to opt out of a public system, exit, which we call it, I think doesn't matter. In one case, in economic models predict the wealthy will always exit, because, of course, as Bob points out, we're redistributing huge amounts of money through this system, and it's to their advantage to exit. When we said anybody can exit, the high income didn't do as predicted. They stayed in the system. They were part of a little society. They didn't know who it was, but they were part of a society. They didn't. When we changed the rules and said, as some countries do, we're just going to let the wealthy exit, in some sense gave them permission. We saw suddenly all the wealthy exited and left just the poor in the system. So it was a very subtle cues by the social context and social regulations that drove huge differences in people's behavior. And so for me, it's thinking carefully about A, the information we give them, and B, what kinds of cues, not just in terms of do we send by the kind of regulations that we create in terms of the kinds of behavior that we're looking for from people. And I think people can respond.
Great. Sorry. The experimental stuff is fascinating. Yeah. Over here, Stephen.
Yeah, hi. Stephen was here. So, Jerry, I want to elaborate a bit on your numbers game. And you think that the growing surplus of physicians will almost invariably create a private market, et cetera, et cetera, et cetera. In the late 80s and early 90s, there were up to 40,000 unemployed physicians in Germany and in Italy. And for whatever reason, and that's my question to you, I don't know the reason, but it didn't alter the private-public mix. And it didn't create a big exodus, and it didn't create a whole lot of parallel thinking. Do you think that's just that there are hardwired egalitarian social democratic cultures in those countries, or do you think there's something else going on? And as a corollary, couldn't one of the other consequences of a surplus be it shifts the bargaining power finally to governments, away from medical associations, and that there will be opportunities to negotiate an accommodation that is closer to a win-win?
So I don't know the details of the German and Italian situations, although I would just point out, I mean, Italy has quite a thriving private system. And so I'm not sure they avoided, I mean, they've already had it. And so, you know, they perhaps got absorbed. I don't know the details of what went on. I mean, Germany is, again, a situation where they have had constant challenges with aspects of the private system and preferential access given to patients with private insurance who are willing to pay privately. So, you know, I'm not sure the fact that they seem to have absorbed it is necessarily going to bode well for our situation, in the sense that the principles articulated in the way we finance it is, in some sense, not to go in a direction that they've already been in those settings. Right? So I take your point. I think how it will play out is unclear. As to the bargaining, I'm hopeful that what you're saying is true. Clearly it's true. Governments are in a position to bargain in a way they haven't previously. The period of previous surpluses in the late 70s and early 80s and so forth, in mid-80s, don't point to governments handling that particularly well in terms of taking advantage of it. And as I say, I think if they do bargain hard and they say we just can't absorb all of you, or you know, we're going to bargain hard on the fees, I guess I still worry in today's environment. There is enough of a private market now and enough out there that the options are different than they were 30 years ago. So I hope you're right, because certainly what you're saying is a very real possibility, but I'm not as hopeful.
Okay, thanks very much, Jerry.
Okay.
Great job, great job. Okay, our final panelist this morning is Francois Béland. Francois is a professor in the Department of Health Administration and the School of Public Health at the University of Montreal. He's also the head of the research axis on health services at the Lady Davis Institute of the Jewish General Hospital there. He holds an appointment in the Faculty of Medicine in the Department of Geriatrics at McGill, and he's the co-director of the McGill University of Montreal Research Group on Frailty and Aging. Francois has been researching health services and healthcare services for the elderly for over 30 years, and he initiated the evaluation, actually, of the first home care policy of the Quebec government. So he's uniquely positioned to comment on the prospects for successful long-term care policy reform in Canada. Welcome, Francois.
Merci. Est-ce que ça marche? Oui. Okay. I don't like to be on the podium. And also because I have graphs, I'm a number guy, so I will have to point on some of the graphs. And also I'm using slides with a lot of words. So if at one point I don't know how to say it in English, you'll be able to read it. So we've been told that this is not about Bob, but I will talk a lot about what Bob teach me, at least. And I'm a sociologist by training, and also by training we thought that economists were all. I would not use the word, will not be nice, but when I was young. And but then when I read Bob's work, then it was my first shock as a sociologist to read things that really teach me things. So here are two of Bob's saying, what he wrote. And they have a lot to do with my topic, that is long-term care, and this will be about my talk will be about that. First, the statement, "Oh Lord, I need a Mercedes-Benz," is a joke. "Oh Lord, I need a coronary bypass," graph is not. And second, so the United States government is owned by the 1%, directly or through the corporation of these people control. Now, it may not be evident that this has to do with long-term care policy, but I will try to show that it is. So there is three questions that I will only be able to touch upon. First is LTC a want or a need, attuned to Mercedes-Benz or to a coronary bypass? And the point is, are illnesses and disability so intricately intertwined that individual experience of acute care and LTC are, in fact, the same story on the same trajectory of care? About increasing LTC costs and aging, we all think that those costs are actually growing. So how about applying institutional ingenuity and where to go? And this is one topic that Bob actually developed. And why is it that LTC is not publicly and universally covered? And this may have to do with the 1% that doesn't want to share their income with the 99% and put money on LTC. So what is long-term care? I like this 92 definition. This is an old idea, but not all ideas are actually zombies. We have to select. Some old ideas actually are very, very good ideas. And so long-term care refer to, this is why I like this definition, is because it's about health and not only social and residential services. While most of the definition and today's definitions are excluding health. I think we cannot exclude health when talking about long-term care. So is it a want or a need? Well, what do we know? I think we know for a long, long time that long-term care has to do with health and services, and also it has to do with needs and not so much about wants. In 1975, more than 40 years ago, about 1 in 5 American aged 65 and over will need a combination of intensive and extensive social and health services. There's no way you can think about a disabled elderly person. You cannot think about his case without considering his health, his or her health, and also his disability. And in the 90s also, frail elderly, they have multiple chronic diseases, require concurrent acute skill in long-term care services, and etc. And also what is interesting, and this is Lutz, which is very well known, of course, 1994. Services manager, look at this, it seemed familiar. The service manager and provider will be unlikely to work closely with service coordination agencies if there is no consideration of concurrent skill in acute long-term care services. To ensure timely referral and smooth transition, avoid overlapping services and cut shifting, will end up providing and reducing community long-term care services to those with short-term disabilities or allow the community long-term care system to support medical care. Sound familiar to you?